He's
Hello, Peter.
he's alive. So I'm going to turn it over to you,
Oh,
Dr. Spielberg. You conduct the fireside chat with Peter.
uh, Peter, that was just fabulous. You know, I've been in this game for a long time. I started medical school 60 years ago, and we used to sit around talking about, how we could deal with genetic diseases. And I remember getting the first 121M Beckman amino acid analyzer, so we could analyze both amino acids and some organic acids in urine, begin making diagnoses. Um, and when I think how rapidly things have changed in 60 years, what really strikes me even more hearing you talk today versus 2 years ago, the rate of acceleration of concepts, the rate of acceleration of technologies, the rate of integration of all of this into the regulatory process. So you can actually talk about doing demonstration projects to see what does and what doesn't work in real time. To me is just utterly mind-boggling. I'm just blown away and very excited from the point of view, particularly as a pediatrician who's taking care of a lot of kids with whoops, something happened here. Am I still there?
Still there. Yeah, we hear you.
Okay. I can't see me though. But let me dismiss.
We can
Are
hear and
we?
see you. We can hear and see you.
Oh, you can. Okay, good. Well, I think the key point is that you can almost taste the rate of change right now that can lead to, as you put it, Peter, platforms that can obviate the need for doing 10,000 different things for 10 diseases, that can begin seeing a future in real time in molecular therapeutics. So congratulations. It was a great talk. And congratulations to the agency for being able to take some of these things on and be innovative. Uh, Two general thoughts. One is how in heck is this going to fit into our healthcare non-system of caring for patients in real time and have clinical resources, both hospital and outpatient, that are going to be able to fit into this. And I'm doing some medical school teaching still. And how in heck are we going to be able to teach this in real time with the rates of change to the future generation of physicians so that in fact they will be skilled practitioners of molecular therapeutics? Those are just philosophical issues, but they are indeed real. Um, Question for you, Peter, and again, this comes to me as a pediatrician, and you were talking about rare diseases. And as a pediatrician, I always think from an ontogenetic point of view, not whether genes are present or absent, not whether they are correct or incorrect, but how they are expressed over time. And I know there's a lot of discussion in the community now about how to apply some of these technologies when you're dealing with a developing and changing person. Obviously, for many of these diseases, we'd love to see treatment very early to prevent any of the sequelae of the diseases. Um, but any thoughts about how to work with the recognition that a child 6 months of age with a given disease is very different than a child 5 years of age with the same disease and the same gene defect. Has there been much discussion? Because I know right now within the pediatric community, there's increasing concern about the ability of the pediatric community to continue doing high quality science. And I know that there have been problems within industry as well about having pediatric groups who can help guide the future of things within the industry setting. Any comments where the agency is with respect to this and how they're thinking about that future?
Yeah, no, thanks. It's a great question. I think at the end of the day, I think it comes to having fit for purpose therapies. There are things that you can expect gene therapy to do, that we can expect gene therapy to do, and it may be necessary to give that gene therapy early enough in life to have it make a difference. It may be for the older child, we're going to have to rely on some cellular therapy that may help stabilize something. I think Duchenne muscular dystrophy would be a great example. It may turn out that at a certain point, trying to give a gene therapy, it's not going to fix what really needs to be fixed. What you might be able to do though is with a cell-based therapy, perhaps deal with some of the cardiac complications or other complications at least prolong life. So I think it's going to be being fit for purpose. I think the other thing that's it's kind of inescapable is that increasingly understanding what someone's genetic defects are early in life may be really critical. And the fact is, you know, I listen to people, and when my kids were born, it was lucky. I didn't have to worry about this for my son, who was a planned homework. But my daughter, when she was born at the Brigham, it was like they came to us from one of these cord blood collection programs and said, "Oh, can we, you know, X number of dollars?" It was a lot of money. I was too cheap. We didn't pay for it, at the end of the day, it probably wouldn't have been useful anyway. But the reason why I'm saying this is that same number of dollars now, less than that, you can have a whole genome sequence on your child, whether it's whole exome or whole genome, and those costs are now getting down into we're now talking for a whole exome to the hundreds of dollars, whole genome, you know, a little bit more, but that getting at these things early may be something to think about, particularly where you have histories, right? Where family history, you know, the whole genome sequencing hit rate is a couple percent. If you stack the deck by having, doing it in the right historical context. So I think my answer to you is that getting, gene therapy early is good. Later, I think sometimes it's helpful. Look, it works in sickle cell disease when you do it but it's not perfect, right? The cost and the anyone who read the New York Times article yesterday on the boy who was treated the first child who was admitted to Washington Children's, it wasn't easy. So the idea here is to try to get these things at a point where you can intervene in vivo in a much more efficient manner. Ultimately, in vivo gene therapies, at least, again, I'll put my stake in the ground. It has to be where we're headed, because it's the way we're going to get there cost effectively, and the way this will become democratized, because I don't see us having, maybe 100 years from now, 50 years from now, I don't see us having scalable cell-based gene therapy on the continent of Africa, whereas I could imagine us, and you could have it in certain centers, but you could imagine a directly administered gene therapy that doesn't require a transplant aspect to be deployed. And obviously, Gates Foundation is very interested in.
Yep. No, that's a great perspective, Peter, and it's something all of us are concerned about, that the science is getting so good, and you can see just over the horizon where the technology will fit into the science to allow us to do things we couldn't do before. Again, having been in the game for a long period of time and talking to my colleagues in departments of pediatrics, medical schools. We also see the potential gap posses of getting both the understanding as well as just the physical setups for how we are going to be able to provide this care. When I trained at Boston Children's, the wards were still designed to take care of iron lungs. And they were terribly designed to take care of kids with illnesses that we were treating in real time then. So I hope there will be some real opportunities, and talking to many of my colleagues who have been in both industry as well as academia, that there will really be some opportunities for cross-functional dialogue, bringing together NIH, bringing together FDA, bringing together AAMC and the residency programs, so that we can in fact begin thinking about how to create a system that will be able to respond to all the exciting things that you've talked about so far.
The ARPA-H program, which was started, they have a fair amount of money, and they actually, they have somebody that they've recruited who is quite visionary in this area, and I think is trying to do exactly what you're talking about. They realize that they need to start with the actual diagnosis in the hospital and go all the way across to the delivery of the therapy. So they're trying to deal with all of those, including dealing with the issue of how we're going to have reimbursement for this in the system. But I have to offer up one thing, though, that is clearly, at least my pet peeve, is that all of this is not going to be possible unless we get the focus on the engineering of how we're going to make these things really cost effectively and efficiently. That's been something we've just lagged behind. Our science is moving so rapidly that you have to remember that actually it took a bunch of geeky engineers to figure out how to miniaturize all of it and make this happen. Yeah, the software is important too, but getting it all this stuff into the box is important, and it's one of the problems with, I think, well, if we really want to get to where I'd like to see us a decade from now, we're going to have to see people put that investment in developing the manufacturing technologies. It's an interesting one. I wish I had if you asked me, if you gave me a bunch of money and put on something, I'd probably spend some more money on that, because we just can't produce these products in a cost-effective way.
Yeah, and I think, of course, the first human genome cost billions, and now we're down to, I don't know what it is, but obviously tiny fractions of that. Some of that has been technology, obviously, but having one son who's a pediatrician and one son who's an engineer, I'm convinced that getting there is going to require a whole cadre of skilled engineers guided by the biological sciences and scientists and clinicians. But that I agree with you completely, and it will be indeed breakthroughs in technology, great breakthroughs in manufacturing. It'll be interesting challenges for the agency thinking about how to regulate manufacturing in a totally different way. And I'm just delighted to hear some of the things that you've been talking about this are currently aimed at accelerating the ability to do that, and having the vision that it is going to be different, because if we hang in the old methods, ain't going to work for sure.